Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Noha Balada from Roots Community Health Center, reporting for the week of October 25th, 2021. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. Alameda County has recorded 118,289 COVID-19 cases. That's up about 1,200 cases than from when I reported a week ago. And 1,415 Alameda County residents have lost their lives to COVID-19. This is an increase of 66 from what was reported last week. In terms of vaccination, we are at 83.7% of fully vaccinated for the county and 81.9% fully vaccinated in the city of Oakland. And while we continue to creep up and our vaccination rates are strong, just want to point out that Alameda County ranks 7th in the state of California, and the state of California ranks 12th in the country. The territory of Puerto Rico turns out to be the most highly vaccinated, followed by Massachusetts, Vermont, Connecticut, and Hawaii. Case rates are coming down nicely overall. We do see that cases, though, are increasing in some states, and those are mostly in the colder states like Alaska, Montana, and Wyoming. And we will need to be keeping an eye on what's going on in other parts of the country as well as the world. We know that the UK is experiencing increasing cases, and it's unclear why that is, but they have identified a new variant in the UK. It's a subtype of the Delta variant. It's called the Delta Plus, or AY42, and this is being called a variant under investigation by the UK. It is increasing. It's now at about 7%, and the UK continues to do a pretty good job of sequencing their variants. We have found a small amount here in the United States, namely in Massachusetts, but the numbers are very, very small here. The reason why this is of concern is because it does appear to be about 10 to 15% more contagious than the Delta, which is already very contagious. It's too early to say for certain whether this is what's causing the increase in cases in the UK or not. Also, too soon to say whether this will pose some kind of an advantage over the Delta, whether it will take over the Delta or not. We certainly hope not. We find ourselves rooting for old-fashioned Delta these days because at least it's the variant we know. It does have a couple of changes that have been identified on the spike protein, which is one of the reasons why this is being looked at. Neither the World Health Organization nor the CDC have named it as any variant of interest or concern yet, but we need to keep an eye on that to make sure that we don't get blindsided by a variant. And a brief update on kids. I know last week I reported from a Kaiser Family Foundation analysis that COVID-19 was the second leading cause of death overall in the United States for the month of September. That was very alarming. But also that report shows us that among 5 to 14-year-olds, that COVID-19 was the number 6 leading cause of death in the months of August and September. So this is highly concerning because it certainly climbed up in terms of being in the top 10 leading causes of death. So for August and September, 5 to 14-year-olds, COVID-19 ranked the number 6 leading cause of death. And in 1 to 4-year-olds, it ranked the 7th leading cause of death for the months of August and September 2021. So this is really concerning, especially considering that the word going around seems to still be that children do fine. It is so concerning that COVID-19 has climbed up the ranks into the top 10 leading cause of death for the past couple of months. And we are grateful that what is on the horizon is the vaccine for 5 to 11-year-olds. We already have a vaccine for 12 and up, and the 12 and up population, 12 to 15 population, still has relatively low vaccination rates across the board. But now we are looking at the 5 to 11-year-old vaccine being taken under consideration by the VRBPAC. Remember, that is the advisory committee for the FDA. They have released the VRBPAC briefing documents, which it's an 82-page document, has been released. I'll go over that in more detail next week, but this is being taken up this week as we speak by the VRBPAC, and then we anticipate, hope that it will be authorized. Remember, the FDA gives the regulatory allowance, and then the Advisory Committee for Immunization Practices will take that up, and we anticipate that will happen at their already scheduled meeting November 2nd and 3rd. And then once they come out with their recommendation, then the CDC will put forward the official guidance and the immunization schedule. Now, what we have heard is regarding the rollout, it's going to look a little different than it looked for adults. First of all, this children's dose for Pfizer is a slightly different formulation. It's a different packaging. It's a different dosage. It is a third of the adult dose, so it's 10 micrograms as opposed to 30. And the new formulation and packaging is reportedly so that it will be simpler for pediatricians' offices to be able to stock and store and administer, and also so that it will be easy to differentiate from the adult dosing. And the White House has stated that this will be distributed to 25,000 pediatricians' offices nationwide. So that is certainly welcome news, and because families are accustomed to getting pediatric vaccines at their pediatrician's office, so that is certainly welcome. Also, we anticipate that all of our children's hospitals will play a major role in administering the vaccines for 5 to 11-year-olds. As far as schools, the state of California has indicated that schools will play a role in the vaccine administration and holding vaccine clinics. It's not clear at this point whether that is something that will happen nationwide, so it'll probably be a state-to-state decision. Also, pharmacies are authorized through the PrEP Act, so that's the emergency authorization from the White House that says that pharmacies can administer the vaccine to children as well, but whether they will choose to do so or not still remains to be seen. So that's something that we will be keeping an eye on to ensure that there will be adequate and even access to this vaccine for 5 to 11-year-olds. And although we anticipate, if everything goes the way it looks, that it could be authorized as soon as November 2nd or 3rd, that the distribution will need to happen, because again, this is not something that any of us as vaccine providers currently have. We will need to receive it after the authorization is complete, and so there will be more to come on that. Just a quick note about the flu. We're heading into flu season. We know that last year we kind of avoided having a flu season, and that was mostly because of a lot of sheltering in, a lot of masking, and we pretty much avoided a flu season, and we don't really know what that means in terms of this year. There's certainly some concerns that it could come back with more of a vengeance. We really don't know. Or maybe we can continue to be cautious, continue to mask, and maybe we can have a lower incidence of flu again this year, but it just remains to be seen. So at this point, the recommendation is that everyone 6 months and older get a flu vaccine. We think that that is important not only to keep you from obviously getting the flu, but also we don't want anyone to be going to the hospital for anything unnecessarily, and certainly not for anything preventable like the flu, which is vaccine preventable. Not as vaccine preventable at this point as COVID, because we know that the COVID vaccines are actually quite a bit more effective at stopping you from getting COVID or being very sick from it. The flu vaccine varies quite a bit from year to year, but still it is recommended for those 6 months and older, and especially if you are in a high-risk group, certainly are very young, or extremes of age, so are very young and are very old, are at much greater risk of getting pneumonia and dying from the flu. So this is nothing to be taken lightly. You can get the flu vaccine the same day as a COVID vaccine, and so if you choose to do that, then you should be receiving them in 2 different sites. So you probably have 2 different arms, maybe 2 sore arms. And so some people may want to just get it over with and get them both at the same time, and that is fine to do. Others may prefer to space it out just because of potential side effects, and wanting to have those on 2 separate days. So, but either way, it is recommended, and we're heading right into flu season, which may be, well, it's an unpredictable one. We really don't know. So now for the booster update. So we are finally at a place where we have guidance for recipients of all 3 vaccines. I'm very pleased about this. It was rather frustrating for those who had received, especially J&J, but also Moderna, to not have official guidance. And so now we are finally at that place. And so just by way of a quick update, a reminder about the role of supplemental COVID-19 vaccines. We have 2 categories, and they are additional dose and booster dose, and these are 2 different things. So even though sometimes they're overlapping, sometimes they get mixed up, I do think it's important for us to keep these 2 different scenarios in mind. An additional dose is the dose after the primary vaccine series, when we believe that the immune response may not have been sufficient due to either an immunosuppressive condition or immunosuppressing medications or treatments like chemotherapy, like immune suppressants after organ transplant, like high-dose steroids. So those were already approved previously, and the guidelines for those are a little bit different. It's actually about getting an additional dose to be considered having received your whole primary series. And that is separate and apart from the booster dose, which is a dose after the primary vaccine series when we think that the immune response may have been fine at the time, but now it has decreased, and it's decreased over time, and now we want to give it a boost. And so the ACIP, the Advisory Committee for Immunization Practices, which advises the CDC, made their recommendation last week, and the CDC quickly authorized it as is. And those recommendations are as follows, and I'm going to go into these in a little bit of detail because there was a lot of information and a lot of discussion, but the committee voted unanimously 15-0 that everyone who has received the J&J as their primary series, everyone 18 and up who received J&J should receive a booster 2 months after their primary series. So I'm getting that one out of the way first because it is the easiest. Everyone who got the J&J as their vaccine should get a booster 2 months after the primary series, and we will talk about which booster in just a moment. Now, for those who had received Moderna or Pfizer, so they've received the 2 doses, should consider, or let me say it like this, the booster will be available for all of those who had Moderna and Pfizer as their primary series 6 months after the second dose, and this is for everyone 65 and up, and also is available to those 18 and up with underlying medical conditions, also 18 and up for those who live in a long-term care facility or other high-risk setting like a prison, like a shelter. Also for those 18 and up who work in high-risk settings. I'm going to get into that in just a moment. And also the mix and match approach was endorsed by the committee. And so what that means is that any vaccine may be used as a booster. Now, which one you choose, I'll talk about how to maybe think about that decision in a moment. But the boosters that were approved are either a half a dose of the Moderna, so rather than 100 micrograms, the booster of Moderna will be 50 micrograms, or a Pfizer, the regular same full dose, or the J&J regular same full dose. Now, first, before we go into how to decide which of these mix and match you would want to receive, let me define some of these terms that were used. So, underlying conditions. And so the CDC has defined the underlying conditions in such a way that a whole lot of people have these underlying conditions, and I'm going to point out some of the ones that may be less well known. So I think we all know that chronic kidney disease, chronic liver disease would count in this category. Also diabetes, heart conditions, chronic lung diseases. This includes moderate to severe asthma. This includes emphysema, COPD. Also, mental health conditions is on the list, including depression. Also, overweight and obesity are on this list. Also, pregnancy is on this list. Smoking, current or former smoker, is on this list. Stroke and substance abuse disorders is on this list. So many people are going to potentially be considered as having underlying medical conditions. So again, the booster is available to anyone 18 and up with those underlying conditions. And I'll talk a little bit more about that in just a moment. But first, I'm going to define what the CDC is calling a high-risk occupation. And they are calling first responders high risk. So that includes healthcare workers, firefighters, police, and staff of congregate care settings like shelters and skilled nursing facilities, prisons, corrections workers. Also education staff, so teachers and support staff at the schools, those who work at daycares are also considered a high-risk occupation. Food and agriculture workers, manufacturing, U.S. Postal Service, public transportation, and grocery store workers. And I want to pull this apart just a little bit because there is a bit of a hodgepodge here between people who themselves are at higher risk of contracting COVID because of the type of work that they do. So we know that consistently manufacturing settings, food and agriculture, retail, grocery stores, these are the sites where we have consistently seen higher risk of workplace outbreaks. And so for that reason, those individuals may be at higher risk of contracting COVID. Now, when it comes to healthcare workers, and the committee did talk about this a fair amount, that healthcare workers are not actually shown to be at increased risk of contracting COVID because of the amount of protective equipment, the investment in all of the different strategies that are implemented within hospitals and clinics, so that we have not seen actually workplace outbreaks for healthcare workers. And so the recommendation really is a little bit more about protecting the healthcare workforce, and so wanting healthcare workers to be more protected so that we don't have healthcare workforce shortages. So I wanted to just point out that nuance because there's a little bit of a difference between you being at higher risk of catching it versus there being an impact to the system or to the public if you were to contract it. So that may or may not play into your decision making, but it's just something that I think many people on the committee, and myself included, think it's important that we be clear in understanding that. So the committee felt, in terms of which booster should I get, the committee felt that flexibility was important. And they wanted to leave this up to really individuals and their healthcare providers. And we know that not everyone is going to be talking to their healthcare provider about this. And so on some level, it does lead to a little bit more confusion. So I'm going to do my best to kind of walk through how I'm thinking about the which booster should I get question. So first, again, for the Moderna, it's a half a dose. So it will be less than if you got Moderna for your primary series, then it will be less than what you got. And it will also be spaced much further apart. So first time around, you got the Moderna 4 weeks apart, 2 shots 4 weeks apart. and you got 100 micrograms. So now if you are at that 6-month mark or later, then you would get a half a dose. So presumably you will have fewer side effects. The side effects are really about the same in terms of which one. So the sore arm and the chills, and could be some headaches, some nausea. So all of the category of side effects was really the same. And it is a little difficult to compare head to head. Is it more, is it less? But I think that being that it is a further spacing and a lower dose, we do anticipate that there will not be as much of what we would call the reactogenicity or some of those effects that we anticipate getting after the vaccine, the mRNA vaccine. The Pfizer is a full dose, and again, it's 6 months later rather than 3 weeks later. So we also are seeing similar side effects, maybe a little bit more in the potential for some local lymph node swelling. And so that's just something to know about. Again, these were all side effects that we're all accustomed to hearing about. We probably experienced them when we got the primary series, and they are all short limited. So basically 2-3 days the most, and then you're back to normal. And same precautions apply. It's great to drink a lot of water, get hydrated, and it's okay to take some Tylenol for some of those symptoms that you might have. Same considerations you might have had when you got the primary series in terms of maybe doing it before the weekend or before your days off, and not giving yourself a whole bunch of things to do right after you get the vaccine. And so at this point, there doesn't seem to be compelling reasons to switch from one mRNA to the other, although many have done it, and maybe there's some theoretical advantage. But if you tolerated it fine, then I think that going with the same vaccine probably makes perfect sense. So you got 2 doses of Moderna, you didn't have anything out of the ordinary, anything unanticipated, then I would probably consider going ahead and doing that for the 3rd dose. Same thing with the Pfizer. And the reason being is that even though the active ingredient is the same, they use slightly different inactive ingredients. And so kind of like, if it ain't broke, don't fix it. If you didn't have anything major unanticipated, I would just stick with that. Now, if you did have some side effects that maybe were more than anticipated, and we've heard people maybe getting a rash that stuck around, for a week, or really any side effect that was unanticipated, then that may be a reason to consider switching to the other. So I think really is the J&J where there's a question about which one to go with. So the J&J, it's fine to get another dose of the J&J. And again, we're talking about 2 months or more after you received the initial dose. So there was also some talk on the committee about, is this really a booster, or should this really be kind of a 2-dose series? We know that it was kind of promoted as a single dose, but is that something that's holding up, or should we really be talking about J&J as a 2-dose? That is not something that was taken up by the committee. It actually seemed like it couldn't be taken up by the committee because the emergency use authorization for J&J in the first place was for a single dose, and their deliberations were really about a booster dose. But that was a conversation, and one of the committee members felt that we should not call it a 2-dose series because of the fact that the booster with Moderna or Pfizer really provokes such a much better response for people who received J&J initially, that they felt that really the recommendation should probably be leaning towards that the booster dose should be of an mRNA. So it's okay to get your 2nd dose or your booster dose being a J&J, but the Moderna or Pfizer are definitely looking like they're providing more protection. So if you have just a strong preference, you got the J&J because you really just prefer the J&J. I've heard everything from, name recognition to a preference for the adenoviral vector. So whatever the reason were, if you still feel strongly about that, then I would say just go ahead and get the J&J. But get something, because with the J&J, it was the most clear that everyone 18 and up needs to go ahead and get a booster in order to have adequate protection at this point. And so again, Moderna or Pfizer looks better than just the J&J as an additional dose, but anything is better than nothing. Now, what about Moderna versus Pfizer? Well, that is very difficult to say. We don't have head-to-head data that really is looking at a Moderna half dose with a Pfizer. We think that in all likelihood, the Moderna half dose probably is going to have less of side effects. It may also have less of the rare adverse reactions like the myocarditis, but without having anything head-to-head, it's hard to say anything very conclusively or for sure. And something like the myocarditis is really mostly a concern for men under 30 years old. And so that may be something to be thinking about in terms of maybe leaning towards the lower dose, the half dose. But again, we don't really have enough information to say that conclusively one or the other is going to have a lower risk. And again, the risk is still much lower than catching COVID, but obviously those are things that we want to weigh out. And certainly if you don't have any underlying conditions and you are under 30 years old and you have received the Moderna or Pfizer, then while the booster dose is available to you, it is not necessarily that you need to run out and get it if you don't have any underlying conditions. If you're in a higher risk occupation, then again, that is a bit of a judgment call. And if you're feeling in a gray area, I would say that would be a great thing to discuss with your physician. But all of the studies were sort of not large enough to, or head-to-head, to make any of these kind of conclusions. I think with more time, we're going to have more real-world data to give us some of that more nuance. But for most people, that nuance isn't going to necessarily change the ultimate decision making. So what I'll say is that in the meantime, what is clear is that anyone who received J&J who is 18 and up should receive a booster 2 months or after the primary dose of J&J. And probably the mRNA is going to give you better coverage. That's what all indications are. But if for whatever reason, whether it's access or preference, you just happen to prefer the J&J, then I think that is a reasonable decision. Now, if you are a woman of childbearing age, you should keep in mind that there is that very rare adverse reaction of the clot that can occur within the brain and with the low platelets, and so that is just something to keep in mind, and it may have you lean towards maybe the mRNA for your booster. Also, if you are 65 and up, you should receive a booster 6 months after your primary series from the mRNA vaccine. So 65 and up, you should receive a booster. 50 and up with underlying conditions, you should receive a booster. 18 and up, if you have underlying conditions, it also seems reasonable to get a booster. If you're not sure, talk to your physician. If you are 18 and up and you live or work in a high-risk setting, you may also get a booster. And again, you may choose to do this for different reasons. Maybe you are you work in manufacturing, it's a high-risk setting, and let's say you have someone elder at home, or you have a child who's not yet eligible for the vaccine at home. You will want more complete coverage. You will want to be more reassured, and so you may go ahead and choose to get the booster for yourself for that reason. Or let's say you are a healthcare worker and you know that being out is going to leave your unit short-staffed, and so you want that extra protection, obviously so that you don't get sick, but also because of your duty during this pandemic, and those are sort of more individualized calculations, and so the booster is certainly available to you and has been recommended, but definitely 65 and up, 50 and up with underlying conditions, definitely J&J, 18 and up, definitely. Now, whether or not you are vaccinated, we still want you to be part of the solution of avoiding the spread and reducing the impact of COVID-19. If you have symptoms, get tested immediately. You should also be avoiding indoor gatherings, particularly in poorly ventilated spaces. If you believe you are exposed, get tested in 3 to 5 days. And if you are positive, please inquire about monoclonal antibody treatment. It is saving lives. Also, ask your close contacts to get tested and isolate. And to maintain optimal health, we all should quit smoking, reduce alcohol, eat a healthy, balanced diet, consider a multivitamin supplement and additional vitamin D supplementation, particularly as we head into the colder weather where we're not getting as much natural sunlight or sun exposure. It's very important that we don't become vitamin D deficient. So please do consider taking daily vitamin D. Also, manage your stress and get a good night's sleep. If you are not vaccinated, then all of the measures that you are doing are likely just delaying your catching COVID. And so at this point, I think we all believe that ultimately, especially with this Delta variant, it will find you. So delay catching COVID by wearing a high filtration mask when you're going to be around others. Also avoid crowded, poorly ventilated spaces. Avoid traveling and gathering. And reduce your risk of severe illness and death. You should obtain a pulse oximeter to establish your baseline so that when you catch COVID, you'll be able to see if you have any drops in oxygen that may necessitate your going to the hospital. Also, get tested right away if you get any symptoms or you think you were exposed, and act quickly to get monoclonal antibody treatment if you're eligible. Remember, there's a very narrow window of when the monoclonal antibody treatment can be given, and so it's imperative that you get tested and with that positive test go on and get treated. And remember the basics: outdoors is safer than indoors, further away is safer than closer together, and shorter time with others is safer than longer time, particularly when you are indoors. That concludes today's People's Health Briefing. Thank you for joining us. Please tune in next Tuesday at 10 a.m. See you then.